Okay. All right. So if you have questions, put them in the chat and we'll deal with them after I get through the PowerPoint because we've got a lot to get through and I want to get us off here at 7 o'clock. Okay. So why are the final rules important for you and your business? Oop. One is that if you're not in compliance, you may end up having your money cut because right now, regional centers budget 50% of it is made up of Medi-Cal funding, and that comes from the Center for Medicaid and Medicare, which is overseeing um, home and community-based programs. And so if the regional center is not in compliance, then that means that they're going to lose that money from Medi-Cal. And so if they lose that money, then they won't be able to pay you. So it's really important that everybody be in compliance that's required to be. And the other reason why it's important for your business is really giving you a guideline to customize services and supports for the folks in your
Wait,
home.
what did I actually do?
Okay.
Sorry.
Okay, so the
No, yo no lo
history,
veo.
we're going to go
Yo
over
estaba
really
Juan
quick.
y Carol.
Can somebody mute themselves if they're talking?
If you could also mute people, you can mute people.
I
if you need
can't
to.
see it when I have the
Oh.
screen share though. So the Center for Medicaid, Medicare, as I just mentioned, funds the home and community-based services. So in California, it funds about 50%. In other states, it funds 100%. We have a client that's in Illinois, and all of the programs in Illinois are 100% funded by the waiver, by home and community-based programming. And as a result, their rates are much lower than ours, shockingly lower than ours. And this all came about because, in the 70s, there was the Olmstead Act that said people with disabilities should move into the community and get services in integrated settings. And then the CMS came back a few years ago and said, you guys have moved the institution to the community. So they were concerned that people were recreating institutions in their facilities. So that's how these final rules came about, because they're trying to encourage, with a bitty big stick, organizations to provide customized services instead of everybody having to kind of do the same thing. When I started working in the field in the 80s, when you worked in group homes, everybody had to eat breakfast at 9 o'clock and everybody ate the same thing for breakfast. You couldn't veer from what was on the menu. 6 people would go on an activity. So if you wanted to go to the movies and somebody else wanted to go ice skating, you had to, flip a coin and everybody did what, people were going to do. So it was a very regimented life. People didn't have choices. Lots of decisions were made for them. There were a lot of rules. Sometimes people couldn't even get visitors, including their relatives. And so these rules were put into place so that services could be customized and individualized for folks. So this is CMS's full court effort to ensure that these services are similar to the kinds of things that we do in our life, because we don't have to wait for a certain time to eat. We can get up and go to our refrigerator and eat whenever we want to. And so these rules are designed to make sure that people living in these programs can do the same thing. So HCBS rules impact residential and non-residential settings, including licensed and certified homes. So FHAs come under HCBS, residential facilities, assisted living facilities, day programs and day program-like services, employment programs. So what does not come under HCBS are, I guess I don't have that one here, SLS, ILS, intermediate care facilities, mental health institutions, and those kinds of facilities. So let's see. Oh, here they are. So I'm going to go through these pretty quickly because I'm pretty sure that most of you have heard about them. because I want to get to the compliance piece, because that's the really important thing that we need to talk about. So the first rule is access to the community. So CMS wants to make sure that people have opportunities to seek employment, competitive employment, meaning that they're paid, at least a minimum wage, and are not in sheltered workshops where they're getting, partial payments. They want to make sure that they engage in community life, control their money and other resources, and that they can access the community the same way that people who are not disabled can access the community. The second rule is choice of setting. And I know from talking to some of you, there's a lot of concern about this one because it's making sure that people have identified and documented that they want to be in the program, either in your home or in your day program. And people are like, well, I don't have any control over whether they end up in my program. And that is true. However, you still need to document that they chose the setting that they're in. And so we're going to talk about that a little bit later. But I know it seems unfair that you have to answer for decisions that people made before they got to your facility, but we still have to figure out a way to do it. The number 3 is the right to be treated well. And this one seems like it would be a given. It seems like CMS would not have to make this a rule. But they want to make sure that people have a right to privacy, dignity, respect, and freedom from coercion and restraint. So that means that, we as providers need to think about ways in which we can make those things happen in a way that the participants feel, the staff understand, and policies, procedures, and practices support. Rule number 4 is independence, and that means that providers make sure that people have choices about what they do on a day-to-day basis, where they're living and whom they're interacting with. Number 5 is very similar to that. It is, choice of services and supports. And so the setting should help participants choose the services and supports they want and also who's going to provide them. So if you are in a day program or some other non-residential program, your responsibilities kind of end here in terms of the rules. The rest of the rules just apply to residential programs. So residential programs are required to now have a lease or a residential agreement, which is a little different than what we had been doing in the past. There's some regional centers are still requiring people to have an admissions agreement, but most of them are requiring a lease, a written agreement that addresses the eviction processes and appeals that are comparable to whatever jurisdiction the person lives in. So they get to have some of the same rights that tenants have, because they are paying rent in the facility. And so we were going to talk about that in a moment. And that the 7th rule is privacy. There's some information about where they sleep. They're encouraging people to have their own rooms, that they will lock their door to their bedroom, and that people who are sharing have a choice of roommates, and that they also have the freedom to furnish and decorate their living arrangements. Okay, whoever that is, please put your phone on mute. The final rule 8 is to schedule and access to food, meaning that people can control their own schedule, that they can eat whenever they want to, they can eat wherever they want to. They don't have to eat at the dining room table or, the kitchen buffet. If they want to eat in their room or outside or some other communal place in the home, they're allowed to do that. And they also have control over their schedules. So if everybody in the home is going to a movie on the Friday night, and an individual would rather go, I don't know, have happy hour somewhere, their staff should support them in doing that. right to visitors. So people are allowed to have visitors of their choosing at any time. This has been a really controversial one for some programs because we all know that there are some participants who are never going to have, visitors coming at 3 o'clock in the morning. And then we also know some folks that would be coming to the house at 3 o'clock in the morning. So this one has been a really tough one for, I know, people in the FHAs because they're living in their own homes. And it's also been some tough for some facility providers too. So we'll talk about that too. All right, and the final rule is that the setting is physically accessible to the individual. And this is another one that's caused a little bit of hand wringing because if you are licensed for an ambulatory home, this one sort of doesn't make a lot of sense because your home is not going to be accessible to the person in terms of, having a ramp or things like this. But it does speak to making sure people have the proper equipment. So we're going to talk about that a little bit later. So compliance with HCBS rules. Some of the ways in which you can be in compliance is to have an updated program design with policies and procedures related to a person-centered approach, training your staff and participants on updated policies and procedures, and also having forms documenting implementation of policies, procedures, and practices. So I would like to encourage all of you to look at this process as a way of transforming your program and your participants' lives instead of looking at it as something that you have to check off a list to get through. Because I know that you all go through a lot of audits. You have financial audits, you have program audits, now you're having HCBS as an audit. And so I think this is a time to really make a difference in the lives of the people that we serve. Because imagine that, they can make all these decisions. I mean, just even 10 years ago, a lot of the folks that we serve didn't get a chance to make a whole bunch of decisions unless they were in supported living or in the self-determination project. And so this is really a time that you can transform what you do and make things happen for people. I remember after I worked in residential facilities and I started working in supported living, I loved it because we could really make things happen for people. We had a guy who wanted to go to the Gay Pride Parade. He was living in a nursing home when he came into our SLS program. And it took a lot of people. It took a lot of time and it was a lot of logistics because this guy was in, a very serious wheelchair with oxygen. But he had his day at the Gay Pride Parade. He also came to happy hour with us. And he was one of the first people I went to the Vietnamese restaurant with the garlic noodles in San Francisco with. So HCBS starts with a person-centered approach. So it gives us license to really listen to the people who we serve and find out what matters to them and how, we can help them make choices about what they want to do. It sort of reminds me of this situation where I saw in my internship where I worked in a hospital and this new resident came in and was presenting his case to the team that was there. And he had all of his things laid out. This is what he was going to do for the patient, and this is how he was going to do it. And I remember the precepting physician said to him, well, when you examine the patient, blah, blah, he says, well, no, I haven't examined the patient yet. And I remember the preceptor said, when all else fails, talk to the patient before you finalize your plan. And that always stuck in my mind because, as professionals, you go to school, you learn all these skills to work with people. And so we always feel like we know it all. And we always have to center the participant in the center of whatever we do. So it's really important that we listen to them and find out what kinds of things are important to them. And so I always think that, if you're looking at modifying your policies, procedures, and practices, that you can really strengthen your relationship with your participants by scheduling time to talk to them in a structured way. And if they're nonverbal, schedule a time to meet with them and their staff so that you can determine the best methods of getting their input, and then talking to people who work with them on a daily basis to find out what kinds of things they like. Um, it's also important for you to put in policies, procedures, and practices things that are related to person-centeredness. So having a participant handbook with pictures instead of narrative might meet the needs of your folks better than, handing them a handbook that's handwritten and very boring. And one of the people that works with us, Ann Ratto, she's done some really beautiful participant handbooks for both residential programs and day programs that are all picture-based and connected to HCBS. I think it's always important to survey your participants and their circle of supports so that you know all the time. So you're doing continuous improvements around what kinds of things they're satisfied with, what things they might want you to do differently as somebody who's supporting them. I know sometimes people don't want to hear bad news, but look at it as a way of strengthening your program. So, and don't take it personally because it's probably not given to you in a personal way. But if something in your program isn't working, it's a nice exercise for you, your staff, and your participants to figure out how you might make it work better. And you won't know that unless you're asking their opinion about what's going on in your home. So if we write your residential program design, we always include surveys for participants, case managers, and circle of support folks. Okay, I'm going to skip through these paperwork grids because I have pulled these out of here. I'm going to give you, so the types of paperwork that documents compliance. So we talked about policies and procedures, handbooks, calendars, and schedules with documented activities. You just have to make sure that if you have a schedule or a calendar, that you go back and look at it to make sure that people actually did the thing on the schedule or the calendar. So you might circle it or check it off or, use a highlighter, but some kind of way you need to document whether the person did the thing that was scheduled if you're doing it in advance. And those people who've had program designs in the last, I'd say 4 or 5 years, your program design is HCBS compliant because they won't approve them now unless they are. So if yours is a little older than that, you want to make sure that you keep those policies and procedures that you've updated on site as part of your administration. So the other types of paperwork, in addition to satisfaction surveys, are meeting minutes. So if you have a resident council that meets, you want to make sure that there's some documentation of that, who was there, the main topics, whatever follow-up needs to happen. We have been recommending to our clients that you actually schedule a time, and by you, I mean you or your staff, schedule a time to meet individually with the participant in the program on a regular basis. We encourage people to meet weekly, but we know that's a lot. So some people have chosen to meet monthly because one of the rules wants to make sure that people are able to change their services and supports before the quarterly report if you are a residential program, or the semi-annual reporting that most day programs do. So let's say, for instance, somebody wants to change their goals. In the past, you've had to call an ID team meeting, and do an ISP addendum, so you'd have to write up a little something that goes with their ISP. So we're encouraging people to set up a structured series of check-ins so that the participant knows that they have an opportunity to talk about things and make choices about changing their schedules, their activities, their programming, and even their placement if they want to. So it's nice if that's in a structured way. And I found that for participants that are particularly difficult, when they know that they have a chance to meet with you, then they're going to save up some of that stuff that might cause them to be dysregulated because they know they have an opportunity to talk to you and things can change. So I highly recommend it. When I worked in residential facilities, when I had really difficult people, I always made arrangements to have tea with them toward the end of the evening tea, and I'd give them a little cookie and talk about how things were going. And they knew they had that time, so they didn't have to like pull me away, earlier in the day for some kind of, you know, issue. So I think it's really important to set up rituals with people, especially structured, time that you can meet with them that happens on the same day as close as possible. And then you document that check-in. So if we did your program design in the last few years, you will have a check-in document that asks a whole bunch of different questions about, are they happy with the program? What kinds of activities they've done in the community? What kinds of things would they like to do in the community? Is there anything that they've heard of that they'd like to try that they haven't tried before? I know most of the developmental centers have closed down, but I would take people who are coming out of the developmental centers. First thing I would do is I would take them to the park in San Leandro that's on the marina, lay down some blankets, and let them just look at the water and the planes landing at Oakland, because a lot of them never saw water because they were in a developmental center their whole life. And it was really a nice experience to sit out there, have a little picnic, and let them soak in the geography. And so I really encourage you to make sure that you are meeting with your participants and staff. When you're training your staff on something new that's related to HCBS, you also want to make sure that you're capturing those minutes. You want to capture training curriculum that you do for your staff and your participants. And I highly encourage you to include your participants in the training that you're doing on HCBS if they're able to participate. You also want to make sure that you're covering some of the things that you're doing in notes or in a monthly activity log. And then under being treated well, behavior plans, especially those written by BCBAs, can be a little dry and not so person-centered and not very positive. And so as an alternative to that, and it's not just our industry, but also the youth development industry. Some of our youth development folks have put together or are required to put together safety plans that the participants put together. So those safety plans ask people what kinds of things will help you be less dysregulated, and they come up with them instead of us coming up with them. And so that's kind of a kinder and gentler way for us to deal with people that have, maybe severe behaviors or some mental health diagnoses or substance abuse issues, or, who are forensically involved. Because those plans are directed by them instead of a professional directing.
Are you going to my house right now?
Okay, I need you guys to mute yourself. And then for folks that are wanting to take their medications independently, it's really important that you document that they're able to do that. And you can document that by having their physician, write that on their LIC 603. Or I know for the FHA that we work with, our nurse can do an assessment to make sure they can take their medications independently. But it's important for you to have some kind of mechanism that documents that, as a liability for you, so that the people who want to take their medications independently can do so safely. So in terms of staff training, you want to make sure that your staff are up to date with all the policy, procedures, and practices that are related to HCBS. Every time you educate a staff individually, you should write it down, have them sign it, and then a supervisor countersigns. And when you do group trainings, make sure that everybody in the group that's getting the training signs their name, and it's also put in their file. And also be good for you to encourage staff to suggest training topics and let them do the training if it's something that they can do to, solidify consumer or participant choice. So in terms of participant training, so make sure your participants are up to date with policies, procedures, and practices related to HCBS. And every time you educate them, write it down, have them sign it to make sure that you're documenting that they received the training, and ask participants in their check-ins what kind of items they want included in their education plan about HCBS. Okay, so compliance tips. So I think it's always important to assign a preferred staff, whoever the participant gets along the best with or whoever they ask for, and have that person meet with them regularly in a structured manner and document that. And then look at all the policies and procedures you develop as those that can grow over time. So a policy that you wrote in 2020 may not be relevant now. And so it's really good to look over them, and maybe you pick something that you can talk to the participants about, quarterly, to get their input. And if your participants have a resident council, that's a good place to talk about it. Also important for you to provide ongoing training to your staff and participants. And I don't have this in the PowerPoint, but it's really important that you go over things like clients' rights and grievances at least annually with both your staff and your participants to make sure everybody's on the same page about those things. Okay, so modification and waivers. So everything in Title 17 can be modified or waived with good pause and proper process. So if you have a participant that would be in a health and safety crisis because of HCBS compliance, you can request a modification. You have always been able to request a denial of rights through Title 17 for people living in residential facilities. People don't use it very much. In my 30 years of working, I've only used it once, and those denial of rights normally have to be signed off on by the client's rights advocate, and most of them refuse, which is why they're not done very often. But depending on what's going on with a participant. So I gave some examples of some participants that may need a modification. So you have somebody who's on suicide watch, and their safety plan requires people to provide close and constant supervision. Maybe you might not want to have that person lock their door. And you might want to get a modification so that the lock is rendered unusable, so that people can closely supervise the person. Or let's say you have a fire setter who requires close and constant supervision. You may not want that person's lock to also be operationalized. Or a participant doesn't feel safe with a lock on their door. They don't want it on their door. Because I know this happened with one of our clients where they had a participant that didn't want to lock on their door, and the regional center HCBS person said, well, that's too bad, they need to have it on there anyway, which was causing behaviors in the home. So that might be an area where you might ask for a health and safety waiver, so that the lock can come off, especially if a participant's saying they don't want it on there, because the whole point of HCBS is that people have choice, and they can choose to go against the waiver if it's a healthy safety issue. Or you have a agoraphobic person, they're afraid to go out in the community or won't go out in the community. You might need to get a modification or waiver for that too. So modifications or waivers are not an excuse for you to be non-compliant with HCBS rules. You have to go through a process to procure one. You can't just say, oh, we're going to have a health and safety modification for this person. You need to go through the process. You need to have an ID team meeting. You need to follow the guidelines around it. And the waiver must be necessary to ensure the health and safety and well-being of a person. Modifications or waivers can only be implemented for an individual, not a group of residents. So you can't get a modification for everybody in your home. It just has to be for one individual person. Everybody has to have their own individual waiver. All of these waivers need to be clinically driven. So they need to be signed off by a licensed person, an LCSW, BCBA, or some other certified individual. And generally, regional centers require clients' rights advocates to also sign off on those. The participant has to agree with the restriction. So if you're trying to restrict somebody who's suicidal, they have to sign on and say, yes, I want, my door to be open, or I don't want to lock on my door. The restriction has to be based on a specific need, like the ones we talked about, instead of some general thing. And in the plan for the waiver, there needs to be a timeline when that right is going to be restored. Because modifications and waivers are only good for a limited period of time. And in the one denial of right that we got, I don't know, maybe 15 years ago, we had to evaluate it every month. And the BCBA that we were working with had to sign off on it every month. So it was a pretty, detailed thing. And you also have to document that you tried other interventions and they were not successful. So the audits, all regional centers in California have to conduct and complete the HCBS audits by August of this year. Organizations that are not in compliance can get a corrective action or a sanction. And if you're sanctioned, it means you cannot get new clients in your home. So providers are going to be given some time to correct some issues that are found during the audit. However, if you get a corrective action, you have a certain amount of time to correct that correction action or be in compliance with it. And if you don't, then you will get a sanction. So the audit is going to include your paperwork and also interviews with participants and staff. And I have, several clients in Sark's area, residential clients who have gone through their audit, and they are telling me that the folks down in Sark are spending about a half an hour with participants and also half an hour with staff, and they're meeting with them individually. So when the participants are talking to them, staff are not in the room with them. So in California, every regional center is different. I highly recommend that you participate in regional centers free trainings, provider meetings, anything related to HCBS to keep yourself up to date with what's going on. Okay. So said that corrective actions and sanctions can be appealed, but that's a real hassle. So I'm just encouraging you not to get one. Okay, so we have developed a lot of HCBS forms over the years, policies and procedures, and those are going to be able to be found in Basecamp under Booster HCBS. And so I'm going to go over a few of those forms in a few minutes to show you some of the things that we've developed over the years. And we also have some samples of some of the documents that some of the people who are going out to do the audits are using to give you a heads up on that. And we've also got some of the orders or circulars that have come out from DDS about it. So just going to show you one more thing and then we can go to questions.
Denise, I hope you don't mind. I've just been putting a bunch of things in chat as you're going along, just talking about how we're doing things here at RCEB, adding on to the things that you've been saying. So people want to look at chat.
Okay. So this is a little cheat sheet that we put together about the paperwork. So some of the forms that we've developed, we have the form number, the name of the form, what rule it comes under, what related policies come under that particular form, and the frequency that you should have people updating those forms. And so this is going to be put in Basecamp so you can take a look at it. Those policies and procedures are also going to be in Basecamp. They're going to be very generic, so you're going to need to, modify it for your program if you decide to use it, but you're welcome to use the forms. Many of you already have the person-centered survey for your program. We have separate ones for different programs. We even have some for supported living and ILS, even though they don't come under HCBS. So feel free to go in, help yourself. And utilize that. So all of that stuff will probably be in Basecamp by early next week. Some of it is already there, but we still need to upload a bunch more. So I'm gonna start taking the questions, and Donna, help yourself to
Yeah.
speak up. Um, okay, so we talked about day programs having to only be compliant with the first 5 rules, and residential providers have to, yes. So key to the front door. So people actually don't have to have a key. They just have to have some mechanism to getting into the door. So it could be a keyless lock. I've been, one of our providers who's in the Lathrop area, Valley Mountain, she has these very neat locks that it looks like a ring, but you just put your thumb up against it and you open a door that way, because she found that some of her senior folks were having a hard time punching in numbers. And keys might be kind of difficult because
Sorry,
people,
I didn't mean, I just meant generally access. They just need to have their own access. It could be a key fob. It could be those numbers. Yeah, I just was trying to write quickly, but we've been focused a lot on the people having access to their own rooms and once again, it's not necessarily a key. I've seen many different types of locks, but the front door is equally as important, and people will get caps. I have seen people starting to get caps if they don't allow their folks to get keys. Now, once again, like Denise said, there are always exceptions. If the person refuses, the person may not want to have a key or access. They may choose, that's their decision, but that has to be documented in their IPP. There has to be a team meeting, and you could get an addendum to the IPP, but that's the default. We're going to assume everyone has a way to get into their own homes, unless it's documented otherwise.
yeah. Well, speaking of that, I have a thing where I have to punch in a code. And today when I got home, I was like rushing and I absolutely could not remember the code. And I realized I didn't have it in my phone. So maybe I need to have a key. Um, okay. Oh yeah. So we want to make sure that the participants are involved in planning their activities. And you will find that if you put together a structure for people to do that, they're going to have the time of their life in planning the thing. So I highly recommend that you have these resident councils, because they're going to come up with things that you probably won't even think of. And when they're doing that and enjoying that, they're not having behaviors. So let's remember that. Um, so, Donna, you want to talk about the thing that you put in there?
Which I put a bunch of things.
Oh, you said that you're specifically looking for training and confidentiality, HIPAA, and I would also add clients' rights. I think that needs to be done every year too.
Yeah, no, so once again, I think Denise said at the beginning, I'm part of the team that RCEB has partnered with to do these visits. So I'm working with Toolworks, the agency that got the contract, and we have about 700 visits to do by the end of August. We're hoping to be at 50% by the end of April. So we have our own checklist, and that's what Denise said will be on base camp. So we are being very transparent. We don't want people to get corrective actions. We want people to be in compliance. So we want you to have the time to prepare. So exactly what we're going to be asking and what we're going to be looking for is posted on the RCEB website, although they don't have the up-to-date forms. But Denise will also post. But so there are some specific things that we are looking for as the HCBS team. And one of them is about rights and confidentiality. That's rule number 3, I think. And we are looking that during your onboarding process, as well as annually, you're spending time with your staff on that issue, as well as when we go around and look at your house. We want to make sure there's not confidential information on the walls. I know in the past it was very common for people to have on their walls, so-and-so is going to the gynecologist at 2:00 on Wednesday, so no, don't do that. So if people have their own private calendars and they want to write their appointments on their own private calendars in their rooms, that's fine. But we don't want to see public information like that posted. And yes, we are looking for that people served know their rights, and that's reviewed annually. A lot of programs do that during the IPP month, when you'll have to do quite a bit of paperwork with your folks, but that is something we're looking. A lot of people do have, a lot of programs do have those rights posted someplace public, and that's fine. That's not, especially the day programs. I don't know if it has to be posted in people's homes, but we really want to know that people know their house, their rights. And I just wanted to clarify with the sanctions that the sanction itself is the last step before, hopefully you'll get a letter that you're in compliance. If you do get a CAP, a corrective action plan will be developed, and you have 30 days to comply. If for some reason you don't comply, and usually, we want people to comply, at that point, I think Regional Center can withhold 50% of your revenue for up to 4 months, giving you an extra 4 months to comply. I think it's after that point, if you're still not in compliance, that there might be a sanction. And I know we're short on time, but Denise, if I could share screen, I don't know if it might be too hard for me to share screen. I just wanted to show the form that we are sharing with the providers about the things, because Denise gave you a very broad, I mean, if you do half of the things that Denise has put in there, you'll be in great shape. And I know all the program designs that Denise helps people develop are very, very person-centered and very, very HCBS compliant. We don't really come in and look at program designs. That's something that FRUC and Regional Center did last year. We're looking at practices. We're looking at, are these things actually happening, and how are you documenting it? So I think Denise was very thorough. Our list is a little bit more targeted, and I think if you have a chance to look at that list before your visit, you'll also be in good shape. We're a few other things that I don't know, Denise, if you mentioned this, but we'd like to see things like the one-page descriptions. That is just a quick and dirty summary of the person, what is important to the person, what's important for the person, what are characteristics they like in the support, in their support staff, what do people admire about them, kind of what are their dreams and hopes. So that's always nice to have. And another thing we'd like to see, and I think Denise talked about meeting regularly with folks, and that is what we call the pre-ISP meeting. Often it's, these big meetings are overwhelming for people we support, and you can get a lot more out of those one-on-one meetings. And we do recommend that before the actual IPP or ISP, someone, maybe a favorite staff, someone the person feels most comfortable with, sits down and talks about, how are things going? What do you want to work on next year? What are some of your long-term goals? I've just learned that, I guess if you're level 2 or 3, your ISP really is just following the IPP. Regional Center is supposed to start writing person-centered plan, but sadly only a few. Okay, we've only seen a few so far that the Regional Center has written. So it's still on you as a program to show that that you have person-centered practices.
Yeah. Okay, anybody have any questions? How many people have had their audit already? Anybody? Okay. Okay. Well, so far, everybody who we've been working with seems to have gotten through theirs okay. I mean, they're not, you guys aren't giving out the written thing at the meetings, so, but people feel like they have gone well. So I haven't heard anybody who has not passed. And hopefully,
yeah, and probably if you're in my cohort, I won't be doing your visit because, well, first of all, I only do it on a part-time basis. I have a lot of other projects I'm working on, but also I don't want any appearance of conflict of interest. So I've tried to have other people do it. And I should say Regional Center is also doing about 40% of the visits. So you might get a Regional Center team. They just hired 2 new folks to be added to their quality assurance team, and they're doing a lot of the visits. But it's, what we work with, we've visited one program that is a 4I, and they have really totally embraced person-centered practices. And they've talked about how time consuming it is, but they have seen an amazingly dramatic decrease in outbursts. They go, we'd much rather spend time working on this and person-centered practices than filling holes in our wall. So it does work. People are happier. People are feeling empowered. People are feeling like they have control over their lives. People are feeling like it's really their home.
Mm-hmm. Yeah. So does anybody have their audits scheduled yet? Twyla, I know your day program's probably too young, but any of the residential providers, have you gotten a notice from Regional Center that they're going to come to do the audit?
Yeah,
Yes.
Denise, we have on the April 22nd.
Yeah.
Oh,
A and K Residential, May 2nd.
oh, okay.
So Denise,
but
also,
we've
when they,
Go ahead.
I'm sorry, when they let us know when our the day is coming, when they're coming out to do the audit, are they gonna send a letter or will we receive a phone call or how does that work? Or
So
do
on the tool work side is one of our team members, Anastasia, is doing most of the scheduling. She'll send out an email to the email that Regional Center has given to us, which is sometimes correct, sometimes it is not. And she will give a date because we don't have a lot of time, and we try to do several in a day, and we try to do it in the same geographic area. So we'll give you a day. If it absolutely doesn't work for you, then you can reschedule, but we're asking people to try not to reschedule. Once it's scheduled, we send out the tool that we use, the questions that we ask, and our checklists, the questions we'll ask your participants or your residents, and how to be compliant form that we have developed. So you'll get all that. And then there's a face sheet that we ask you to fill out, which just talks about your program and get it back. And I think a week before the visit, they'll be calling you or emailing you to confirm.
Okay, and how long does these audits usually take?
Great question. It's been taking on average, I'd say about 2 hours. As we're getting better at it, it really depends on the program. It's also in how prepared you are. I mean, we've come into some programs that are like, here's our HCBS notebook, and everything that we are looking for is in one place, and it's great. But we do like to spend time. My favorite part of this whole project has been interviewing the participants, people served, nonverbal and verbal. It's just been delightful. And then we'll go through and we'll tour the home. We'll tour the programs. Sometimes we go to community-based programs and we meet at a Starbucks. We also try to be very respectful. If someone doesn't, we're doing provider meetings once a month, and someone says, well, we have a resident who's a hoarder and she doesn't like people to go in her room. And it's like, well, that's her right. We're not gonna force our way into anyone's room. We're not gonna interview anyone who doesn't want to be interviewed. Usually, we're fine with you guys deciding who we interview. We're there to help. We keep on saying that at some point, we know the feds are gonna come to California to make sure that everything we're saying we're doing. They're gonna come out and they're gonna visit, they're gonna randomly pick programs. Our job, we think, as you know, as part of this HCBS process, is to help you all be ready. So if the feds come and they come to your program, there aren't gonna be any issues. So so we're there to consult and help and support. It doesn't mean that everything might not be perfect right away, and you might get a corrective action, but hopefully it's for a little thing. Sometimes when we're there, people are making changes right as we're sitting there. We went to one site visit, and while we were there, they went and made keys. They went to the hardware store and made keys for the residents. So we're there to be helpful as helpful as possible and to make it as stress-free as possible. We know no one likes evaluations or visits, but everyone on the ToolWorks team has been a provider. We know what it's like to be on the other side of this.
Okay, my last question, and I'm done. Would it be wise to just have like binders separate from our regular, like our other binders that we have for each resident, just for the HCB?
That's what I'm recommending to our folks. And I was also going to say that I'm training somebody on our team to go out to our clients' homes to look at their stuff before they get their audit. And so, because we did a lot of validations and remediations last year. And so we're reaching out to everybody who we did a remediation or validation to. And I'm suggesting that, whenever you have any kind of audit, it's always good to put all of that information in one place so that people are not rifling through other things.
Right.
Because one, it's none of their business what else is in your file. And
Mhm.
two, they're going to come in and out much quicker if everything is in a binder. So what we've been doing with some of our folks, because I've been out to a few people's homes already, is, we make a binder with 10 tabs in it for each of the rules, and we put all of the forms and documentations under those tabs. And so when they come in, I had one person even take pictures of the participant's room because the participant had this amazing mural on the wall, because they asked the participants, oh, how would you like to decorate your room? And one of the participants says, well, I want a mural on there. So they paid an artist to do this amazing mural. I mean, I'm going to put that in the HCBS stuff because I thought that was a great idea. So we took some pictures of it and put it in the binder under that section. So yeah, I'm very big on specific binders for stuff so they can come in, look at the stuff, and then go have their conversations with the participants. And then, so we had that binder for the participants. And then we also had an administrative binder where the HCBS training logs were kept, the updated policies and procedures, because some of the folks that we work with have had, homes for 30 years. So they haven't updated their program design, but they have updated their policies. So all those policies were in the administrative binder. And then we also had like the combinations for people's keyless lock in there. And I forget what else was in there. But so we had two binders, an administrative one for the program and then individual binders for the participants.
Okay.
Yeah, we've only gone to a couple of programs where people have like that binders. We jump up and down with joy when we see something like that. So we're happy to that. And we're really, the other thing that makes us happy is when I go into people's rooms and their personality jumps out at you. You walk in and, two people in the same room and they're, each half of the room is totally different. We had one house where, half the room was painted blue and half the room was painted green because one of the people wanted blue walls and the other wanted green walls. And I've seen some really creative stuff, the way people do schedules and pick activities. It's kind of, they have meetings and it's kind of like a menu of people's preferred activities, and they just circle what they want to do next month and initial it. And, it's awesome. A lot of pictures for people who are, can't read. And yeah, I've seen some really creative, wonderful things. But, I've also seen things where people are doing things the way things were done 20 years ago, and that's not okay anymore. But it's been great, and I think you'll all do great because you have all the support and guidance. And like I said, if you do even half of the things Denise is suggesting, I'm sure you'll be in good shape.
Yeah. So those of you who are running SLS programs, you don't have to worry about the audit. I mean, you should worry about making sure your practices are person-centered, but you don't have to worry about the audit. And if you want to schedule a time for me, and Marilyn is the person that's going to be coming out to the homes to help people get their stuff together. If you want to schedule it, if you're already in Booster, you can just talk to your advisor about it. If you're not in Booster, you can shoot me an email or a text. And so this PowerPoint will be in the HCBS section of the Booster, and I'm also going to put those paperwork schedules in there too.
Denise, another question. I noticed that we're calling the residents now participants. Should we stick to that name? I mean, using.
I was using that for day programs. So because I don't know, some of you might have day programs. So when we go to day programs, I just say people, but commonly the day programs will call the people and the people they serve participants, and the homes will call them residents.
Okay,
So since I didn't know who the audience was, that's why I'm using both terms.
got it. I just
Okay.
wanted to know if it was a change.
Yeah, no, it always changes, but it's what people want to be called. So that's what I
Right.
always check with. But yeah, I think that most commonly day programs are calling the people they support participants, and
Got it.
most homes are calling folks residents.
Okay,
We're not calling them consumers anymore.
right.
Yeah.
Either
When I got into the field in
binder-
1985, we were calling them patients. So
Oh,
it's
Mm,
evolved over the years.
yeah,
It's hard
okay,
to keep up, but it does evolve.
right.
Yeah, hi. This Alfonso. That's the question I also want to ask for the SLS programs. How do we call them? Because I see some agencies calling them clients.
Well, I think you're pretty safe if you call them participants or just by their name.
Okay. All right.
Yeah, it's whatever you feel comfortable with or what they like. I mean, what they want to be. I know I stopped using the word clients, but that's just me personally. But other people, the system, I think DDS still calls them consumers in all their paperwork. So I don't like that term at all. But
Yeah,
it's a
okay.
personal choice.
So it's safe to call them participants on SLS.
For SLS,
Mhm.
yeah.
Okay.
Yeah. So as I mentioned, we have a person-centered survey for most services, even the ILS and SLS. And those surveys usually have the what's important to, what's important for, and what people's desired goals are. When I was working with one of our clients, the HCBS specialist and I went over every form they had in their company and we modified it to make sure it was in compliance with HCBS. It was actually a fun project. This is Jacqueline Lawton for those people who knew her when she was at GGRC. So we worked pretty closely to get all that stuff done. So it was a learning experience for me too. I learned a lot from working with her. So so that stuff I think should be pretty good. And I think we also have some one pagers we can share too in the HCBS from some of the training that Mainsail did at RCEB. There's some really good trainings that were going on. I haven't noticed them this year, but I know last year they had really good trainings in HCBS. Those were some of the best trainings I've ever been to. So
Yeah, I have some good tools. Denise, we have some docs that we send out regularly after visits, one pagers, pre-ISP meetings, a few other things that we're pulling together. If you want, I could just send it your way and you could add it to your library.
Okay, that sounds good. I think we have a sample of the one pager and what my perfect day looks like, or some of the stuff that Mainsail was giving out. It's on there. So, all right. Well, it is 7:04, and so unless anybody has any more questions. Okay, so this particular training, we have to beef it up a bit, but we're gonna get it turned into CCL so that the next time we have it, it will, you'll get credit for your CCL hours. So, okay, well, good night, everybody.
Good night. Thank you, guys.
Oh,
Bye-bye.
Denise,
Thank you.
I'm sorry, what?
I just realized I have a quick question. Some
Okay.
of my members, we were talking, and they really enjoyed the group meeting, but they feel like, including Alfonso, was wondering if they could come even earlier, 30 minutes, so they get to know each other, exchange phone number, learn about each other's program, since everybody's already there, or stay after. And I said, I have no problem. Then I thought, wait a minute, someone has to open a door. So what's your thought on that?
Yeah, I mean, we're usually there a half hour ahead of time. So sure, people can come when they want to.
Oh, great.
I
So
think a half hour, maybe not an hour, but a half hour would be okay.
okay.
Just make sure somebody's going to be there.
So Alfonso, can you hear us?
Yes, I can hear you.
Okay.
It's fine. As long as we as the providers on like half an hour early, and that way we know each other more and know about each other's program, and rather than talking when actually the program is going on,
So we'll be there. We'll be there. So feel free to come earlier, 30 minutes before, and we get to know each other more before we start the presentations. The second thing is that many of our members asked about the employee handbook.
Mhm.
I think you address it. If they can get one from, where can they get one easily? Denise.
Yeah, they just need a referral to the HR consultant.
Okay, there we go. All right.
Yeah.
Thank you so much.
Okay.
Nice seeing you.
Okay, thank you. Thanks for the invite.
Bye-bye.
Thank you.
Bye.
Thank you.
Okay.